Thank you. We now invite Dr. Sarashandra to speak on intraventricular tumors.
A very good afternoon. It's a great pleasure to be here and to be listening to these excellent teaching lectures. And at the outset, I would like to thank Professor B.K. Mishra for having given me this opportunity and also congratulate him on organizing this wonderful congress. So I would be speaking about the increasing role of using minimally access endoscopic surgery for intraventricular tumors, particularly the large intraventricular tumors. Is there a role for endoscopy nowadays? Now, if you see the various endoscopic techniques for intraventricular tumors, you could have a pure endoscopic technique where you could do the entire surgery underwater. So one of the classical prototypic lesions is a colloid cyst, and of course you can also use it for smaller lesions like a septal gliomas, or you can do a biopsies. But for large intraventricular tumors, it absolutely becomes unfeasible because the blood itself takes away the visual. So in that case, we would prefer to use some kind of an endoscopic assisted surgery, and that is what precisely most of my lecture would cover. Now, the endoscopic assisted surgeries, what I have done are either the midline interhemispheric approaches or a transcortical approaches using a very small flap of 3 into 3 centimeters. Now recently we have got this robotic system which we use very aggressively for our epilepsy program, and it definitely has some advantages, even though it does even have some disadvantages. It's not working. So it allows 6 axes of motion and also 3 degrees of the rate of motion, which could be slow, fast and medium. And I think it buckles up as a very good endoscopic holder, especially for such kind of surgeries where you need to do a very fine meticulous dissection. Because it does not allow any kind of surgeon exhaustion because of the haptic feedback mechanism. So whenever the lever's magnetic locks are released, the whole weight of the system doesn't fall onto the surgeon's hands, and it allows the systems to be maneuvered in any direction. And we have been very, very effective of using this technique in developing 2 seminal surgical techniques in epilepsy. One is an endoscopic hemispherotomy, and other is an endoscopic callosotomy along with commissurotomy, which is now recognized as one of the fundamental techniques for epilepsy surgery. Now obviously when we do the surgeries, they are going to be long. So in which case the ergonomics of the surgeon is very important. One cannot say that I'm going to stand on one leg and I'm going to do I think those days are gone. So it's very important to have an optimum back support. It's very important to have an elbow support. So I prefer to use long scopes for all these cases, and it's also very important to maintain a very good visual axis. So if the visual axis is maintained in a very uncomfortable position, after some time obviously it becomes very difficult for you to continue with the surgery. Now the main advantages of the robotic system, what I found is that it's a very stable holder, provides an haptic feedback, no exhaustion absolutely for the surgeon, doubles also as a neuronavigation device. But the main problem is, it doesn't have any active movement. The movements are slow, and sometimes it can actually freeze. So it's not a perfect system. So this is the kind of flaps I use for doing the transcortical endoscopic assisted surgeries. And initially I was trying to use, as I will show you in one of the videos, a transparent sheath. But ultimately I found that it's not very useful, and the best way to do this surgeries is to use a dynamic retraction with both suction as well as bipolar. And for interhemispheric approach, I use the same kind of craniotomy what I use for endoscopic hemispherotomies and corpus callosotomy, a 4 centimeter into 3 centimeter flap, and that's the kind of system we use. Now coming to endoscopic colloid cyst, we published this paper way back, and now our experience is over 94 cases. So fundamentally we have 2 techniques. One is we use a 50 cc syringe with a 3-way to aspirate out the contents, which could be very thick, And this is followed by a biportal technique, and we in fact described this technique several years before, I think almost 8 or 9 years before. Now, navigation tethered to electromagnetic based system also is a very good mechanism by which the suction can actually be converted into a neuronavigation system. And this is useful especially when one goes into the depth and one tries to see for the limit of the tumor. So I have some videos which runs exactly for 9 minutes, and I think I have that much amount of time. So that's an example of a colloid cyst. So again, this is an underwater surgery, so pure endoscopic surgery. So you would have seen this kind of surgery many times before. But I would just like to point out to one caveat. Could you please reduce the lights? It's too much on my hair. So when this mucoid material comes up, it's usually very difficult to suck out this. So the system I use is one which is attached to a 50cc syringe, which is with my assistant. And moment I introduce the catheter inside the colloid cyst, he aspirates it. And once he aspirates it, then it turns the three-way, and then the whole mucoid material can be siphoned away into the normal suction system connected to the three-way. So this is one mechanism by which the mucoid material can be very effectively sucked out without it going into ventricles, which can actually increase or enhance the risk of aseptic meningitis or even development of delayed hydrocephalus. And following this, we use a two-port system by which we're able to cut out and take off the capsule. Now, in colloid cysts, I found that it's not necessary for us to be extremely radical. That is, there is no need for us to completely take out. So even if a remnant is left along with the colloid plexus, most of the times we have not seen a recurrence happening. Go to the next case. Now this ends with a septostomy, which I do it in all my cases. That's a post-CT. Now, the endoscopic assisted interhemispheric approach, as I've shown earlier, we use a craniotomy of size 3 into 4 centimeters. And again, I heavily rely upon the haptic feedback given by the robotic system. And I use a long telescope. So that now this is completely under the endoscope, under high magnification, so you do not see the circle around it. That's the brain being dissected off from the fox and then separated to one side. Exposing the corpus callosum. And you can see the yellowish discoloration because of the lesion. And the blood is sucked out, and then the capsule is being dissected out. Now you can see I'm doing a dynamic retraction using just the suction and the bipolar, and this is what I found is the most effective way to perform surgeries in most of the cases. That's the end of the surgery. That's a post-op. An example of a recurrent large neurocytoma, which was done through a transfrontal. But because most of the recurrence was towards the midline, I decided to again go an interhemispheric approach. Now in this case, the brain was quite full because of the tumor, because of which initially I used the brain retractor. Now keeping gel foams both in the anterior interhemispheric and posterior interhemispheric, especially when the brain is full, provides a very good interhemispheric retraction, and that's the tumor. Now as and when more and more tumor is being decompressed, the brain starts becoming lax, and you start seeing more and more space, and that's the end of surgery. So that's a post-op. An example of an optochiasmic glioma. This child came practically in emergency with this large tumor. Again, we use an interhemispheric approach. I did a left-sided because that is where the tumor was coming onto the surface. So you can see the tumor now coming to the surface here. We open it, there is a cystic cavity, and we start decompressing the tumor. So we can use the micro CUSA, which is like the endoscopic CUSA. It's a very thin profile and can go in very, very easily inside. So obviously in optochiasmic glioma, we wouldn't like to remove the tumor which is at the basal part, which is encasing or infiltrating into the hypothalamus. So we'd like to shave it till the level of the foramen Monro so that the hydrocephalus is resolved. That's a post-op CT scan. Now the transcortical approach is an advantage, especially for large tumors coming onto the surface of the cortex. For instance, in this case of a large neurocytoma with a large cystic component. So you can see this was one of my initial cases where I tried to use the transparent retractor because in theory it looks very attractive. But you can see there is a severe limitation of the space inside. So the retractor itself takes up a lot of space. And this tumor was extremely vascular. But the best part of removing such tumors is you need to stay exactly in the midline, and as you patiently go on decompressing more and more tumor, the brain itself pushes the most of the tumor to the midline. And as we decompress more and more tumor, the hemostasis also becomes much more easier, and at some stage suddenly you'll find that the whole bleeding stops. That's a post-op after 2 months. Now this is the last video which shows a large intraventricular meningioma again approached through a transcortical approach. Through same 3 into 3 centimeters craniotomy, again using a robotic guidance. I'm not pitching in for the sale of robotic guidance, but I'm saying that it could be done through a transcortical approach. So you could see it's highly vascular. Once again, I'm using a dynamic retraction with only suction and bipolar. So I can fast forward this. So tumor, using the CUSA, that's the end of surgery. That's the size of the opening. That's a post-op MRI after 3 days. So these have been our results. Interhemispheric approach in 15 cases, transcortical in 12 cases. It's an initial study, but as I'm doing more and more cases, I'm becoming more comfortable. Colloid cyst, of course, we have a huge experience in several years. A drain is a must because the blood needs to drain out, not only to drain out the blood, but also to prevent post-op hydrocephalus. Now, concluding, minimally access surgery, especially in intraventricular tumors, I feel is an advantage because the brain pushes the tumor into the center, prevents brain swelling and its complications, and endoscopic definitely has a good control for bleeding and excellent visualization. I feel that the best way of doing surgery is to by the dynamic retraction with suction and bipolars. So thank you. So summarizing, at the end, 4 years from now, we would be organizing the International Society for Minimally Invasive Neurosurgery Congress in the beautiful city of Udaipur. So there's a lot of time for you to plan this holiday. And for people who are interested in epilepsy, we are going to have a very good, and Professor Mishra has said that we could do it along with AASNS. And we have this workshop, masterclass on epilepsy as well as epilepsy surgery to be held in BHU Varanasi on 21st to 23rd November. Thank you very much.
Yeah, very interesting and impressive presentation. If the field is clean, neat, endoscopic view is great, but if the tumor is bleeding, at any time you felt like moving to microscope, and what is your advice to the residents?
That's the reason we don't use pure. I stopped using pure endoscopy for large intervention. It's impossible. You just cannot use an endoscope. So I use an endoscopic assistance, and endoscopic assistant works out fantastically. Your telescope is quite away from the bleeding, and you have very good control. And yes, all these tumors initially will bleed, but as you keep on working about it, the bleeding will reduce, and you're able to take it off.
What is the additional advantage of having this endoscope assistance when a microscopic, that's what we are used to, when microscope is available? What additional advantage do you get by using the endoscope?
I found that it's a minimal access surgery, and for intraventricular tumors, I don't have to do large craniotomies. And for intraventricular, the tumor is pushed into the center. So it's not like a glioma that you have to make a big craniotomy and go to each and every corner. So we are basically dealing with a tumor which is exactly in the center of the brain. And there is a huge raised intracranial pressure. So as we start decompressing the tumor, the whole tumor would come exactly into the center. So I think it goes very well with the philosophy of endoscopic approach. But if you're comfortable with microscope, I've never denied microscopic approach.
No, we don't need anything bigger even in a microscopic surgery. The size of craniotomy would be the same.
Can carry on with microscope.
No, just to add a point,
Yes.
I think eventually when our experience and techniques evolve, we may be able to do many things with just a borehole. Even intraventricular tumors, it may evolve. Young people may take it forward.
This time in Russia, I found a surgeon, and everybody was flabbergasted. He was doing huge tumors just by boreholes. He spoke in Russian, but we could just see the pre and post-op scans, and everybody were really impressed. And this includes large acoustics. So that era is already coming. So I think it's just a step to move forward into a different perspective. And I know, sir, you have a lot of experience. You can do it with microscope. That's a fantastic way to do it. But this is also another way to do it. And I'm becoming comfortable with this as time progresses.
I think
Yes, Professor K.
doing hemispheric. Yeah, please go ahead.
It's a very impressive presentation. You made the comment when you were showing the colloid cyst that you're not particularly aggressive about removing all of the cystic wall. I certainly found that early on when I didn't remove it, I did get a small number, but a significant number of recurrences. And now I am more aggressive about removing the cyst wall. I wonder, what's your recurrence rate?
I'm sorry, I couldn't get you. You're saying what's my construct?
No, your recurrence rate for colloid cysts.
Recurrences. See, we had to reoperate 4 cases because of recurrences. But what I found is, once we decompress the colloid material and even partially cut the capsule, the rest of, I don't know, that's what our experience has been. I don't know if your experience speaks better. And
No, I just found that when I wasn't as aggressive with the capsule early on, I got an increase, I got a significant number, small, but perhaps 4 or 5 recurrences over the years. I'm talking about over 40 years. And when they often recurred later. They didn't recur after 2 or 3 years, but you had to wait 10, 15, 20 years for them to recur. So I was interested, whereas when I would get more aggressive with the capsule to really make sure I've removed it, I haven't had any recurrences.
I'll keep that in mind.
I'd be interested to know what the recurrence rate will be.
I'll keep that in mind. That was one thing.
It doesn't mean that you've got to follow them up.
Yes,
you must make sure
that's
they're followed
critical.
up.
I think that's critical. You are 40 years down the line, he's probably 10 years down the
10
line.
years.
So that's the difference.
That's a very good suggestion. Because I'm always concerned that, and I'm always curious that should you remove each and every teeny weeny bit of capsule which is attached to the choroid plexus or maybe sometimes to the vein. So if
There
you
is
feel-
data in the literature what Dr. K said. I mean, when you do a minimally invasive, this is also, there's a publication from Phoenix, this Barrow Institute. The recurrence rate is higher when you have done endoscopic, like you leave a little bit. And the time is the factor. I mean, 20 years down the line, if you have another problem in India we have is the suspect, follow-up suspect. You know, they either they cannot come back because they can't afford to it, or they get to another person. Whereas in your center, probably they all have to come back to you. So you don't have a choice but to see your recurrences. We have the advantage that we may not see our recurrences.
Well, Dr. Yadav, your comments, please.
Yeah, only two things. One is that if you cannot remove the total wall of colloid cyst, then the rest of the wall you should coagulate. So this reduces chances of recurrence, number one. Number two is that when you do endoscopic treatment for deep-seated lesion, if you use tubular retractor, over the years I have seen that it helps in reducing the bleeding.
What
So
retractor?
if there is
Tubular retractors.
tubular retractor, what you were using, I use different kind of.
I know you
tubular-
make it yourself.
Yeah.
You
So if there is a bleeding, I just push it deep and it controls bleeding. So this is one advice.
Thank you, Sarath, and this is very interesting and educative session. We thank the speakers and then audience and then close the session.
Thank the chairpersons. Feels heartening to see a full hall at 5 p.m. in the evening, and we start off 5:40. Yeah, that's the